My name is Angela Dunn. I'm an assistant director in the Coombe Women's and Infants University Hospital, and I'm here with a number of my colleagues today. And basically what I'm going to talk about is the introduction of the productive ward into a postnatal ward. It's called our ladies' ward, and it has 36 beds, but it also has 36 cots, so it really has a capacity for 72 patients in total. And it's a very, very busy ward. We decided to introduce it into our ladies' ward, basically because it was probably the worst ward in the hospital to actually work in. It was extremely busy. Everyone was so busy they couldn't even stop to see why they were so busy. So it was a challenge, but we took it on board. Sorry, now which one arrow did I use? So this is the picture of the Coombe. We have a maternity unit, we have neonatology, gynecology, and it's a standalone unit, and we have about 9,000 births per annum. So the productive ward, how did we actually start off? Well, it's a national project, and we were picked as one of the 17 pilot sites in Ireland. It's guided by a national steering group, and you will hear about that later on. We have a national coordinators in each area, and the NHS has an institute input as well. The Coombe is, our ladies' ward was chosen, as I said, and we had external and internal supports. So basically, as I said about our ladies' ward, it's a 36-bedded ward. There's 20 WTEs, midwives, 5.5 healthcare assistants, and 1 clerical staff and 1 support staff, our household staff and catering. And our average length of stay is 36 to 48 hours, so it's quite a quick turnover. And the average number of admissions and discharges on a daily basis can be anything between 15 to 20. So our first step, how did we actually go about this? We set up a steering group, that was first, and then we started productive ward training. We set up a multidisciplinary team. We started brainstorming on how we're actually going to move forward. We developed our mission statement, which took a while, and we set our goals and aims and our key performance indicators as well. And we then started our activity follows. We started with the foundation modules, the knowing how we are doing, the well-organised ward, and patient at a glance. So basically, with the well-organised ward, we did our activity follows. We did a lot of video waste walking as well, and we learnt a horrendous amount from that. We did our spaghetti diagrams, our process mapping, our 5S approach, took a lot of photographs, and this is an example of our ward inventory list. And actually that pulled a lot of people coming into the ward, the multidisciplinary teams, people from outside wondering what was this, and it actually drew the attention of that we are introducing productive ward, and started asking questions and wondering, well, this is not going to work in our ladies, it's such a busy ward, there's no way you're going to manage this. We did our stock rearranging, and we reduced a lot of extra stock and overload that was coming into the ward. A lot of stock was actually walking off the wards as well, so we put a stop to that. Our equipment trolleys in each bay, our ultimate aim was to try and get the midwife into the bays with the women, rather than being running up and down the corridor. And the corridor, it takes 35 seconds to go from one side of the ward to the other side of the ward. And you could have about 10 interruptions while you're walking up and down. So if a patient asked you for medication, you'd go down to the lock press, and you could be 15 to 20 minutes going to get the medication. So we had to put a stop to that. So we decided the best thing we actually did was get the trolley, a medication equipment trolley. They're locked to the walls in each of the bays, and everything is in it that the midwife actually needs to do her work. The one thing about these trolleys was we got the staff before they go off duty to actually stock them up. but that wasn't working. And it was actually a pharmacist turned around and says to it, well, why don't you stock your own trolley first thing in the morning? You're the one that's using it for the day. You'll put into it what you actually need for the day so that you won't. And it was actually a great initiative. Small things, but it's the multidisciplinary approach. It's other people coming in with their ideas and giving people the voice on the floor to make that change and follow up and sustain it. This is our, basically, sorry, I didn't finish there. Just going back. It's a small win-wins that actually got this going. It's having the equipment in the right place, down to a drip stand. You could go to 6 wards to actually get a drip stand. The Dynamap, you go to the Dynamap, there's a blood pressure cuff missing or it's not working. So it's identifying a space for that. Dynamap, that everybody knows where it is. I'm finished using it, I'll put it back, and the next person goes to it and it is working and ready for use again. And it's just doing your audits, rechecking, make sure that it is actually sustained. And we did an awful lot of that. The IV medication and storage prep area, that was from one of our videos. We videoed somebody doing the procedure of preparing IV augmentin or whatever. And it took 20 minutes to half an hour. Again, they went this press for that and that press for the other, down to the bed for the cardiacs, back up again, get a second person to check. So we identified one area in the ward, in the treatment area, and we labelled it IV preparation, and we put all our stuff, everything that we actually need for that procedure into the one area, and we cut it back down to about 5 minutes to actually do the procedure. Nominated key holder, that was basically the DDA keys. Again, the person in charge, when you want to do DDAs, where is she? She's bottom of the ward, she's top of the ward. And it's just finding where that person is could take up to a half an hour, not half an hour, 15 to 20 minutes. Again, being interrupted as you're doing that. So we decided that in the first top ward, that the senior person would hold the keys, and that person was the only person that had the keys. You got the keys off her, you returned the keys to her, and that in itself saved an awful lot of time as well. This is our stores. It's a very old building. This is not ideal. It doesn't meet any standards, the wood and etc. But it's the best we had. We didn't have funding. This is not about getting funding. It's about making the changes with what you actually have. So basically we labelled everything and put it into the right place, so when you go in you can actually reach it without having to fall over a number of drip stands first and then go look for what you have, or you go to the next ward for it either. But in the meantime we've actually got funding, and we put in a business case, and we're upgrading now our C&M2 office and our stores area and our nursery, and that's gone to tender at the moment. How were we knowing how we were doing? Basically, what we did was we did patient satisfaction surveys, we did staff satisfaction surveys, we sent our newsletters around the hospital, we used our intranet. Our patients' complaints have literally dropped. We've none at the moment. We haven't had one since October, which is absolutely great. The compliments are flowing in. We have private patients that can't afford private care anymore and have converted to public. And they are coming through the system, and they're saying that they had a better experience on the public ward than they did in the private ward. And that in itself says an awful lot. Clinical risk reports, we watch them very closely. We watch our falls, we watch our low temperatures in our babies, low blood sugars in our babies. We also watched things like the readmissions coming back in. We have there actually, you can see them actually dropping as well. The audits, we do a load of audits. Now they're quick and smart, and you know they're not time consuming, and that's the whole secret with the audit. That's not time consuming. We do the incoming calls. We were getting an awful lot of calls from the delivery suite looking for beds, and we could get up to 20 before lunchtime. So as a result of that, the audit, we decided that we would have a bed manager in the delivery suite, and that actually has cut down the phone calls enormously. Also, as a result of the phone calls, public health nurses ringing in from the community. We looked to see at the information that we were sending out, and we've upgraded our computerised discharge information, and that has reduced phone calls as well. Infant feeding charts was another audit that we did, because they weren't being completed and peds were actually giving out, or not giving out, but it was causing a lot of problems on their side. The linen room audits, hot water, even down to hot water in the rooms. You know, the mothers going to the sinks to get hot water to wash or bathe their baby. It was very slow to heat up, so we did an audit on that. The requisition kept going down, they kept coming up for repairing it, and this went on for a little while. But following a number of audits and saying, look, this has to change, and it did change. And now you don't have to walk the whole corridor and carry a basin of water from one area to another. The room equipment I've talked to you about, GP folders, again, it's about having the things in the right places, that midwives ain't walking from one side of the ward to the other. And meals at the beds. Patients, we feed our patients at a table within the room, because we try to get them to actually communicate. But the women don't like that. They want to be at their bedside. So this is something that we have to do. We have to make changes with the meal module, hopefully this year. Patient at a glance. This is something we've extensively reviewed, and it's advocated by Productive Ward, but we've reviewed our own system, and we have a computerised ward list that generates a lot of data for us that we use for our reports, and reduces down the time for our reports as well. There's very little writing, all the information is actually there. So after a long discussion with our multidisciplinary group, we decided, no, we're keeping our own system. It's working well. And we've actually tried to amalgamate it into a new system that we're starting in February. It's an inpatient management system, and it'd be better bed management system that we have already. Admissions, planning and discharges, I told you about phone calls. One of the best audits actually we did was we looked at the reason why we couldn't get mothers out in time in the mornings. It was always 12 and 1 o'clock before the bed was actually vacated. And we actually found an awful lot of information when we did that actually audit. But the reasons, and it was just enormous. I said, gosh, where are we going to start with this? And basically we took each of them, and we target our goals, and we've re-audited. It was done last February, and we've re-audited in January. Basically, our investigations to be reported, we have brought down to almost 5%, very, very low altogether. There was another one, awaiting medications, we've down to 1% as well. So each of them we've targeted in, and we are making great strides, and it's amazing the changes that it's actually. Like, we don't do FBs or certain, I'll talk about that in a second, I'm coming on to it. But that was powerful, and we're still working on it. And that's basically maternal hemoglobins. We have that down to 5% at the moment. PCRs, we don't do it anymore. This was a blood test that we do on babies. We looked at the literature review, and basically there's no evidence for it. We went to our neonatal team and said, why are we doing this? It takes 20 minutes to actually take this blood sample from a baby. There is no evidence for this. So as a result, we got stopped. It doesn't happen anymore. So it's not just about winning, it's about looking at everything that's going on and questioning everything that you're actually doing on the ward. Why am I doing this? Is it necessary? And is there something better we can actually do? Another big win-win for us was the serum bilirubins for the jaundice babies. We always send a sample to the lab. Again, it takes up to 20 minutes to get that small sample of blood. And we've introduced, looked at the best practice, and we looked at literature as well. And we decided that we would trial a billimeter, the new serum bilirubin meters, and it only takes 10 seconds to 15 seconds to take a reading. Now, if the reading is high, we will do our blood sample, but we've cut down our serum bilirubins to 1 or 2 in the day, whereas we could be sending up to 10, 15 some days. And I told you about the PCRs, the blood sample we did with the babies. The FBCs is another one. On day 3 sections, elective sections going home. Why were we doing this? Where's the evidence to actually do this? So we've decided that we would educate our mothers going home. We would advise them to go on Galfer. Those that were symptomatic, we would do a blood sample, but otherwise it wasn't actually necessary. And again, that has eliminated enormous, it's cost-wise, it has brought down our costs in a big way. And time as well. It can as you say, it can take 10 to 15 minutes to do an FBC. Another of our KPIs was to get 15% of our mothers and babies discharged again 10 o'clock. As you know, the demand for the beds is very, very high. And following, as part of our audit, it's all combined really. So basically, this is the time before discharge. We have set up a system where we can actually calculate exactly on a monthly basis our target. We're getting out, in March, we got out 1.7 again, 10 o'clock, and in December we got out 4.67, and before 11, 6.7, and in December is 12.36. And that actually has gone up even in January. We've gone up to 23%. So we are getting there. And that makes such a difference when you see the win-wins. The midwifery procedures, the changes in investigations, the clinical equipment I've spoken about, the clinical trolleys, and the SaO2 monitor, that was another win-win at the very beginning as well. It would take up to 20 minutes to do an oxygen saturation on a baby. The probe was wrong. We got the company in, we changed the probe, and now it only takes about 5 minutes or less to actually do it. Other modules, medication. We've actually introduced a new medication, Cardix. We've noticed with our clinical risks that our medication errors were quite high, and that is ongoing at the present moment. We have done a pilot, and we're gone back again. We still have it right. The shift handover, we've moved to our nursery to make it more space, and we're looking at ways maybe to cut back down that time. The ward rounds, patients with the charts at the bedside, and that in itself is enormous for continuity of care from the midwife to the obstetrician. We have no midwifery cards, no separate notes, we all write into one. And as I said, with your equipment you have your charts, so you don't need to leave the beds. It has reduced errors in admissions, it's improved the patient's experience, it's empowered the women, and it also has reduced time wasting. Patient hygiene, we have a lot of work to do there yet. There's some IR issues that has stopped us, or union issues that has stopped us to date, but we're ready to roll, I think, within the next few weeks. Quiet time initiative, this was enormous, and it's only something very small, it cost absolutely nothing. Basically, we noted that the number of babies falling out of mother's arms because they're pure exhausted was actually beginning to rise, and we were wondering why. Are they not getting rest? And so we decided that we would implement a quiet period in the afternoon or in the evening time. And we had resistance at the very beginning, but once the doors close, the whole place, it's just the air calm comes over the whole place. And the midwives absolutely love it. The patients love it because they're getting a rest, and it's like, it's one of the best initiatives I think we've actually done, and it absolutely costs nothing, but the satisfaction both from patients and from the staff is enormous. So our productive ward, what have we achieved? We've achieved time released to care, increased patient satisfaction, money saved, and increased staff satisfaction. And just in summary, our total time saved was 2,740 hours, or 10 hours per day. And actually we see that, we feel it, our students actually feel it. The feedback from the students, they're not looking for extra supports that they used to look for, and they're getting better teaching as well. The activity follows before and after. We actually have just done we did an activity follow last year, and we've just finished it before we came over last week. And we have increased our direct patient care time by 13% for midwives and 13% for HCAs, which is enormous. Leading to clinical improvements, our incidents have actually reduced. We've reduced infection. Our mastitis rates have really reduced, and our wound care has reduced, and our readmissions have actually reduced. The complaints, as I said, have actually stopped. We haven't had one since October. The compliments have increased, but most of all, the increase in the staff satisfaction is absolutely enormous. There's actually a complete major culture change. It is one of the hardest wards to actually work in, but their team has really come together, and the sick leave has actually dropped. The students feel happier, and overall it has sent a message through the whole hospital that this works. We've started to roll it out in another ward. The enthusiasm from the other ward, they just can't wait to start. They feel they have a voice. They want these changes. They have all these ideas, and they just want to implement. And I just have to say, there's one midwife in particular. This is why it's so important to listen to your staff on the ground. At one of our multidisciplinary meetings, we were talking about getting our patients out again 10 o'clock, and she said, well, why am I getting them out for 10 o'clock? If I get them out for 10 o'clock, I'm the first to get the admission coming from the delivery suite. And I'll get all the you're punishing me by me getting the patients out. And we just said, God, that's right. So the decision was made then. Our suggestion came is, well, we all have a low risk, women. You discharge low risk, you discharge your first low risk, and we all take one then as they come in, rather than the one person taking one. And do you know something? It made sense, but we were so busy we didn't see it. And our total savings, we've saved about 8,032 euros per day, approx. And I said that the ward refurnishment, we're going ahead with that. Another system that we actually looked at is actually, we were going to implement it hospital-wide, is electronic reporting. It's the filing in lab forms, and the whole system around that. The time is enormous, and we have a business case actually put in for that, and hopefully with the help of God we will get that in time to come. So the challenges we face, motivating the team, time is a big issue, and if it is worth putting the time in, because if you get the win-wins, people will voluntarily give you the time. The ward activity is a challenge, the current ward layout, communication again. It's like every organisation, communication can be it's very difficult. We did have union issues, and resources are always an issue, but we succeeded. So what's next? We need to maintain motivation, sustain our achievements, ongoing audit schedules, the refurnishing of additional clinical equipment. We need to look at our meal module. We need to improve our team approach with specific grades of staff, and address our discharge delay key performance indicators. And we need to roll out, as I said, the productive ward to other wards. Thank you very much.
Thanks. Are there any questions before I move on? Just a question on you've reduced your number of complaints. So before October or November, what was the number one complaint you were having, and what did you do as a team to reduce it?
We have a complaints committee in the hospital, and basically we encourage patients to send in complaints if there are issues. We investigate the complaint. Be it whatever it be, if it's multidisciplinary, it's usually at my level, at assistant director level, I will actually do the investigation. I either talk to the staff that are actually involved, and basically, we try to find out what was the cause, what can we learn from this, and how can we actually improve. But we also meet with the patients, depending on the level of the complaint. But we always write them a letter initially to say that we are investigating it, and then we follow up then by meeting with them, or by a letter, or whatever is required.
One of the things we were getting were verbal complaints, in addition to the formal ones that were sent, and they were generally around time. Like either meds were late, payment was late being given, and it wasn't enough time to have breastfeeding or something like that. And that because the time we've saved in other areas has been redistributed into patients getting an hour time. like enough feeding and the support needed.
Yeah.
Thank you very much, Andrew.
Thank you.